It's really a pleasure to join with all of you and what I believe is one of the most critical issues facing the health and social services systems in our nation. I say this from observations and experiences, which I want to share with you a little bit, of almost 55 years in social work and the allied health and human services. I've also had the opportunity, as Erica mentioned, to serve at both the county level, at the state level, and at the federal level. As commissioner, I had a broad responsibility for health and social services programs, including child welfare, the Medicaid program, mental health, developmental disabilities, juvenile justice at one time, and the list goes on. It's given me a bird's eye view of what I would call the disconnects that occur in the human services due to a lack of communication, a lack of collaboration, and a lack of services integration. I believe, as a matter of policy and economics, we cannot rely on ever-expanding resources to meet the needs of those we serve. Further, I also believe we have become over-specialized in our professional practices and take responsibility for only one part of the issues that families and individuals experience. Without professional collaboration, without systems integration, we will never achieve the outcomes for individuals and families and communities that we are collectively capable of. Today, my goal is to provide an historical view of the nature, impact, and evolution of this issue. It is not a new one, and there has been no shortage of efforts to address it. I will also suggest some of the reasons why it persists and some ideas in specific areas to create serious improvements. This has been kind of a labor of love for me through the years, and probably one of the most difficult ones. The bottom line here is that we need a change in our professional and academic cultures to truly address this problem, and I've kind of outlined it for you. It's not new, but one of the most fundamental lessons that I learned, experienced in the course of my work, is that the problems that individuals and families bring to us don't fit neatly into any bureaucratic boxes or particular agencies. People have co-occurring disorders. Families that are struggling need services from a number of agencies. We identified this early on in the 1970s. There have been many state and federal initiatives to drive integration, but only very limited success in defined areas. I'm going to tell you a list of my failures in this too, because I tried a number of things. Some of them worked a little bit, but a number of them just didn't go. I think when you think about it, part of the issue is in the years of practice, there's been an enormous expansion of agencies providing services. And right now, for example, we have, of course, local government, county government, state government, federal government, nonprofit agencies, for-profit agencies, hybrid organizations, faith-based organizations, and others. So it's often difficult to really package together, through good case management or care management, a uniquely tailored package of service that families need. And even those of us with lots of experience have difficulty doing that. I'll give you an example of how I did personally. But there are some manifestations of the dilemma. Let me give you one that was a very troubling one for me. It was the disconnect in child welfare and domestic violence. We had many a situation that was literally heartbreaking, where a mom was being severely battered. And the police were involved, we got called in, and the husband had a record of violence. And we said to, ma'am, you ought to get a restraining order. And you have to understand, if you work in this field, that's the most dangerous time for a victim. When she steps forward to say, this is unacceptable, I'm going to do something about it. So when she failed to follow through, we would, in child welfare, take the kids. Think about that. So here's a woman who comes to us for help, and our response is to take her kids away. A disconnect. Mental health and substance use disorders, similarly. It's really good to see the evolution where those two divisions have been combined. People now think of this as behavioral health, which is a vast improvement. But back in the day, I got to tell you, people would ping pong back and forth between the systems. One system would say, you know, we can't deal with you until you deal with your substance abuse program and problem, and vice versa. We've come a long way from that, but we still have further ways to go. Child welfare and public assistance. Here's a thought here. Many times, having been a former DIFAS director too, remember DIFAS back in the day? Many times, the families that came to us, the major issue was often poverty, employment, housing, not necessarily child abuse or neglect. But the disconnect was that people got trapped in our system. Kids went into foster care for years, whereas if we had served in a more rational, collaborative way, we could have kept that family together. And only later did programs like family preservation and others come forward. It's been a long disconnect. There's many innovations and federal waivers around this today around the country that help to divert families in need from the child welfare system and get them the economic and social and health support that they require. But we still have a ways to go. Mental health and developmental disabilities was another issue. When I was commissioner, I was responsible for all the developmental centers and psychiatric institutions and hospitals in New Jersey, and we didn't know what to do with people that had affected both. Only more recently have more responsible programs have evolved to understand the unique needs of individuals that are duly diagnosed with both problems. So it's a disconnect. And many parents, if you think of it from this standpoint, had a long trail of effort and grief and rejection for their loved one. Why? Because nobody wanted to take them until we developed more specialized program. Another issue that really still affects us today is the disconnect between primary health care and behavioral health care. This is a big one. I'm going to mention this again in a few minutes, but I don't know if you're aware, there's state regulations now that if you're providing mental health services and health services, you have to have separate entrances and separate waiting rooms. Think about that for a minute. Not good. But now we've recognized the interconnection of those two issues and are trying to establish systems and programs to be able to deal with them. We have a long way to go. Some of you are familiar with the issue of equity in insurance. Let me just clarify for the little. If I, God forbid, today walking around and fall in a funny way and break my leg and I need like 7 or 8 operations, God forbid, my health insurance will probably cover most of them. But for psychiatric type issues, often there are limits on the days of counseling and limitations on therapies and treatments. So we have to work towards the integration of both to have a reasonable response. You've probably seen, some of you work in the health system, people back up in emergency rooms that need institutionalization or some kind of care, waiting for screening days in this environment. Got to change that. We also have another manifestation of the dilemma is we have what I call stovepipe IT systems. Let me explain what I mean. Oh my goodness, this is, when I was in government, we operated so many helpful programs, public assistance, TANF, food stamps, and a whole array of others. Each one required a separate application and a separate IT system. They couldn't talk to each other. So wouldn't you think it would be simple to design one system where you put in the basic facts about people and a whole list of programs they're eligible for comes forward, and not only that, tells them where to go to get the program, what they need to bring with them for verification purposes. In this day and age where we can book airline flights, rent apartments, do all those things on the net, why can't we unify it for that? We're very fragmented that way. And we also have the regulatory disconnects that I mentioned before as well too, where some regulations in state government actually make it more difficult for the kind of collaboration that we really require. These are some of my failures, I guess, or tries that didn't work. I haven't talked about this in a long time. It's bringing back some painful memories, actually. A long time ago, a leading policy person in the state said, why do we have separate child welfare and separate welfare agencies? Why not have people, let's take away the stigma of child welfare, let's do it together. and I actually led a project to combine on a sample basis Middlesex and Monmouth's child welfare and welfare systems. The union's concerns, the salary issues, the different days for holidays between county and state made it absolutely impossible. And it was abandoned. It was a good try. This next one is kind of funny, and it recognizes the complexity and difficulty in collaboration. I was very fortunate when I worked for the county. We got one of 5 grants from the federal government. They're very significant ones. It was called the National Long-Term Care Channeling Program. And the idea was that if we provided nursing and social work services in a collaborative way, along with home care and some wraparound funds and things like that, we could reduce the expenditures for nursing home costs and keep people happier and more productive in their own homes. It's not rocket science, but they wanted proof of it. Freeholder isn't here today, but you know, with those kind of research grants, you have to have a control group, an experimental group. So the program, there was such need out there, we had a huge outpouring of people, and my freeholder's grandmother got randomized into the control group. That was a real problem, I can tell you. So, you know, it was really fun. So people would come in and we developed these service plans for them. We developed things like, we were the first to use, you know, that advertisement you see on TV where I've fallen down, I can't get up, and I can push a button. We actually had that system in. It was really good, and I think we really made a difference. And in the midst of this, when I was working in Middlesex, my family lives in Essex County. My mom calls me, and she says, you know, I hear you're an expert witness, you know, or going around the country talking about this program. Well, Mr. Expert, we got a problem with your dad here, and I want you to come and fix it. Do the same thing, whatever it is you're doing in Middlesex, do it for him. So I took off a couple of weeks of work. You know, I rolled up my sleeves. I worked for 10 years in Essex County, so I knew a lot of the people. You know, it took me over a week and maybe 50 phone calls, meetings, all kinds of things to develop a rudimentary plan for my dad. And here, Mr. Expert was supposed to be on top of this. And I wonder, how does your average citizen deal with a loved one that's failing? There's so many issues, things like Meals on Wheels. Yeah, you know what I mean. Okay. Next one was, this was a lot of fun. It was way early for its time. We decided, remember we talked about the computer issues, the IT issues? We created something on a demonstration basis in a couple of volunteer counties called One Easy Link. I doubt anybody remembers this because it sounds familiar. The idea was, pardon? Yeah, it probably did. It became nightmarish. But the idea was that the application process was so hard for people. Public transportation isn't the greatest. There's a complexity of programs. So why not have a system where there's no wrong door? So you can go into any agency, hook up with this system, apply electronically to all these different programs as necessary. You can make appointments, you get maps how to get to the other agency. The idea was it was one easy link, no matter which door you walked in the health and social service system. Boy, that was a fight. First of all, my colleagues in state government didn't want us to do it. They wanted to more control the information. They had all kinds of issues about it. There were legitimate technical issues about it, but it was a good idea. And there's no reason why we don't have something like that today. The idea is access. And, you know, I started as a caseworker. And I was a welfare worker. And, you know, many times my clients needed a multiplicity of services. And I would say, go here for there, go here for that, here for this. And I would think about how difficult that was for them with small children, with trying to meet bills, buy food, all the stuff that people have to do. And oftentimes they would fall off the grid and just give up. I just can't do this anymore. I can't go to these counseling sessions, this session and others, because of the hassle of getting around, getting to the agency. So the thought that one easy link could be good. The big issue I tried, that fell flat on its face, was I came up with this idea. It's going to sound a little strange to you, but I was so troubled about the lack of integration, I decided I was going to reform the Department of Human Services immediately. I was actually going to eliminate all the separate divisions. And I was going to have a geographically based offices. So no matter what your problem was, we'd have a case manager there that could deal with all of it. It would take away, some constituencies did better than others than lobbying the legislature for money. Want to have a unified system, no wrong door. Again, you walk into your county department and you're hooked up with whatever services you need. Everybody didn't like that. The only person that liked it and why it stayed alive was the governor thought it was a pretty good idea, but it didn't work. Some of it was sad, where the constituencies sometimes feel that their needs are special, their group is special, they don't want to be mixed up with these other folks. That was unfortunate. But at the end of the day, that was a lot of the reasons why the effort failed. No one's done that in the country, but it was an idea. This actually happened. My fifth or sixth day on the job, I get a call from a court clerk who tells me, you know, the judge here up in Passaic County is raging. He's going to issue a warrant for your arrest. You know, I was stunned. I said, what did I do? What's the issue? She says, you have representatives from 6 of your different divisions on this case, and all of them are pointing their fingers at each other as to whose responsibility this family is. So if you don't get down to this courtroom and figure it out and tell me how we're going to help this family, I'm going to arrest you. He was bluffing a little bit, but we did come up with a unified plan, but it was so difficult. I mean, that's how it works. I mean, this family had child welfare issues, there was a domestic violence issue, and there's substance abuse issue. The list goes on and on and on. And we got to do better than this. We got to do this. Some of the good responses have been the evolution of what I'd call case and care management, with and without the ability to approve and have services paid for. So the idea of having a single case manager, or care manager as it's called in some contexts, to sort through the varying and different types of services and come out with an individually customized plan with the client's support and leadership, so that you get something that works, that's comprehensive in nature. What we found is that sometimes it could be even more effective if the care manager has the authority to trigger payments for the services. And managed care does that. In some ways, managed care was tended to coordinate healthcare services in a way. The effort was to try to get the clients, the patients, the best possible care they could, but no more, no less, and that you'd be coordinated. You had one physician case manager. It was a good idea, but I'm not sure we ever realized the benefit or potential of it. Sometimes managed care became managed costs, and things required pre-authorization and other limitations to people getting services. But it's a good concept, the idea of having it, and it's a reflection of what's happened. We need somebody to help a family, an individual, figure out exactly what they need and come up with a plan to get that. It's one of the most important things, and it's something that social workers do all the time. The next one isn't really a collaboration issue so much, but it gives you a hint of the cultural problem we have here. And there was a point in time, this is many years ago, where we had centralized health planning. Anybody remember this? There were something called health systems agencies. So that before anybody got a new expensive piece of equipment, like an MRI machine, or they were going to expand their facility, that they had to get approval from a central agency. Why was that so important? Because when hospitals build or add, the costs for those get added into everybody's bill. So the idea was, if we don't need like 100 level 1 perinatal centers. Those are those centers that can keep a little baby less than a pound alive. Why don't we have them by regions? Wouldn't it be more cost effective? We could still do it, and we do it the best we could. Why not have regional services? It actually worked for a while. And the idea was to cut down on duplication, maximize the cost, still provide access to people, but it collapsed. What do you think it collapsed? It's a culture we have. You know, everybody wanted to compete with everybody else in the hospital. Some of you may be familiar with Central Jersey. We had a level 1 perinatal care for very tiny babies. And we thought, based on health and healthcare projections, that we'd only need one for that part of the state. Well, every hospital around has one. They're popular, but we all pay for it. when your insurance company pays out, when you get a bill, God forbid, if you don't have insurance. One of the reasons is the difficulty in regulating the marketplace for health and human services. Okay. Sometimes we did some, managed care is an interesting concept, and I want to talk to you about it for a minute because I think it may be the wave of the future. I know a lot of you are interested in mental health and come from behavioral health backgrounds. We're going into fee-for-service now. Does that ring a bell? It's a very controversial statewide issue. And in speaking with the commissioner and others, the idea is the next step will be capitated managed care. Let me tell you what that is and what it works. It's very important to understand this because it's going to drive the evolution of much of the health and social services. A good example I can give is when I was responsible for Medicaid in the state, we enrolled about 500,000 people into managed care programs. The reason we did that, you know, it was really interesting. Sometimes these revelations are become personal. I had a son that loved to ride a motorcycle, right? And he always got these dust-ups and got road rashes. So I took him in the hospital one day in an urban setting, and the place was packed. People were waiting hours and hours for service. Trauma cases were being wheeled in as we were sitting there. And, you know, I can't sit still, so I walked around. I started to talk to people, and I saw, you know, a young woman with a young baby, and I said, hey, how's your baby doing? I said, okay, she's just got a little cold. And I'm saying, why would you want to take your baby to this setting and watch these trauma cases come in and wait 4 or 5 hours? And she's like, well, I can't find a doctor in this county that'll accept Medicaid. So I get all my primary care here. From a management standpoint, that's the most expensive bill you're ever going to get from the emergency room. So we realized that we could save money by creating networks and have a dynamic that worked like this. We would pay a flat rate for every enrollee, okay? And this is a concept that's coming to all the fields. And an insurance company who contracted to do that would only make money if they kept people healthy, basically. Because if they spent too much on institutional care, they were going to lose money. So all of a sudden, managed care companies started to pay for like gym memberships and stop smoking programs. So it's a good idea. It doesn't work completely, but the idea of kind of figuring out a cost, that same concept's been applied in child welfare, developmental disabilities, where the idea is to somehow control the market in a reasonable way to keep costs. I got to tell you, all the debate about healthcare, from my perspective with Medicaid, which is an $18 billion a year program now, is before we fix the whole system, we got to control costs on the program some way or somehow. They're absolutely devastating. So I also tried some specialized initiatives. We had challenge grants. We would give out money for a particular service, usually mental health and substance abuse, that if you built a collaborative in your county, that was a real plus to you getting the grant. So it kind of drove collaboration that way, that it was a requirement. Limited success. We had a governor's initiative once that we designed where we were willing to give families a flat amount of money and they get off the waiting list and they could arrange their own care. In some cases that worked as well too, but it's a hard way to go. There have been some successful initiatives. Everybody familiar with PAC teams? Yeah, it's a great multidisciplinary collaborative approach to individuals with serious and persistent mental illness. The idea is we don't wait for clients to come to our office. We know that certain patients we have are going to be resistant to treatment. They're going to be out there in the community. They need help, so we go out and see them. Okay, so I think PAC teams were a good success. The children's system of care. You all have care management organizations and crisis intervention services throughout. The idea there was the first time New Jersey, I can't take credit for this, I wish I could, but it was the first time the state thought in terms of systems of care, that they looked at the individual and the family and say, given this situation, what is the array of services and supports that are required to keep this child in the least restrictive environment functioning at the highest level and the family together? And they funded those programs and services. Some of you are probably a part of those. It made sense because it involved collaboration between mental health professionals and social workers and a variety of other disciplines. The courts found these very helpful as well too. And it is an example of how collaboration between different fields can really, really be successful. That's our one example. We haven't been able to replicate that in many other areas. I'm going to talk about it in just a few minutes, but one of the most driving demands we have is a system care for behavioral health, which we do not have now. And it should be driven by the opioid epidemic. I mean, there's an opportunity with the massive impact that's had on our communities, on our people. It should be hopefully a stimulus to get it done. Some of you are familiar with school-based youth services. That, I think, is an excellent example. We have over 100 school districts now. We're providing comprehensive services to kids in school in a non-stigmatizing environment. And it's taken on a life with school. So kids who are experiencing problems with grades, thinking about dropping out, being bullied, having difficulty with sexuality, depression, whatever it might be, they can see, for example, a licensed counselor during a study break anonymously. It was a real breakthrough. Here's an interesting one, and why it's only been partly successful. Are any of you familiar with something called the Family Justice Center? They mostly started at Norton. The data on murders, on serious injuries, are very stark. And what they realized is what I was saying before, is that we want people to come forward to make complaints, to get restraining orders, but it's such a risky population. Also, there's a lot of other services victims require. So in several counties, particularly in Essex County, I was very happy to be the first board chair of the Essex County one. They had a program where they co-located, think about this for a minute, the police, the prosecutor's office, civil legal services, a connection to a shelter, a child program for the kids who were waiting in the office, the ability to not have to go to court by telecommunications with the court to get a restraining order, and a whole lot of other things. So all the agencies are housed in one location that's secure. In Essex County, the number of homicides dropped considerably. It was tough. Everybody had their different approach as to how you work together and what should be the solution. But working together, I give credit to the people. They figured it out and now do a great service to children. Here's a dilemma with getting funding. And it's not a criticism, it's a reality. For years, I think we've underfunded our domestic violence programs. So many of the fierce advocates for that said, wait a minute, before you go into a new model like that, why don't you fund us greater? You see what I mean? There's no funding source for collaboration. People, it's kind of a sophisticated idea in some ways. People will respond more to, we got to help battered women, we got to help hungry kids. But when it comes to the financing and effort on pulling it all together, it's very limited. So it's been a struggle. We've been in business 5 or 6 years. We're hoping to start a movement throughout the state. There's a couple other counties involved. But it's a wonderful model, and it has some real potential. But that's one of the problems. I get into the funding sources. It's, sometimes we do this by hard experience. The first week or two, I was child welfare director. We had one of these heartbreaking cases in South Jersey here, where a foster child almost starved to death. He was brought in on a failure to thrive diagnosis at the hospital. And as a new director, I wanted to find out what happened. There was concern. It seems like there was a breakdown. How can we let a child starve to death in foster care yet? So I go down there. Everybody was upset. I thought I was going to go down there to fire the worker. But I really wanted to find out what happened. And I met with this very young woman. She may be 23 years old. By all accounts, an excellent worker. And she was in tears. She was really scared. And I said, all right, let's just walk through the case. Maybe we could learn something here. And by all accounts, from her supervisor, she got a lot of things for that family, that foster family, clothing, all kinds of things. But she said to me through tears that, Mr. Director, I'm an only child, and I'm not sure about development. I had some thoughts about that, but I didn't know what to do about it. And until the reason the child is alive was that she came back unexpectedly one day to have the client sign a paper, and she saw the child in a pamper and could see the emaciation and the danger. So the child almost died. So out of that, we realized, why don't we have a relationship with advanced practice nurses? If we're going to do child welfare, shouldn't we have that capacity to train our workers, to be there for resource requests? We actually added them to the offices. That's a good example of collaboration. I hate to have to do that, though, to fix what was a bad problem. I wish we could be, prospective and see it happening and plan for it. But those are the kinds of successful responses that occurred. These are small areas relatively. There's a lot more to do. What are the barriers? It's always turf. Always turf. There always will be, probably. But we can put pressure, I think, to overcome that. I control this. That's an area of expertise of ours. Go away. Don't bother us. Control is part of it. More important ones are the lack of funding reimbursement for collaboration. We're in a world of fee-for-service, so you don't get paid for. If you talk to agency directors, they don't get paid for doing some of the very nice things they used to do, the extra things. They only get paid for what are the costs associated with the particular service they're getting. There's no box or code that you can bill for collaboration. So if I'm a hard-nosed manager and like many nonprofits who haven't gotten the cost of living adjustment in years, I'm only going to have the workers do exactly what is required to do for the state to get reimbursement in that case. Nobody pays for this. That is one of the bigger problems that we have. Another one is communication. Sometimes we even lack a common professional language to speak to each other in. Words between the different professions have different meanings. There's a lot of misunderstandings out there. The opportunity to talk it out, to have meetings, conferences that are multidisciplinary like this, focusing on the subject, I think is a great opportunity. There's also the old thing of competition for dollars, before. People in philanthropic, in agencies more and more, your agencies probably too, if you work in the nonprofit sector, are more and more dependent on philanthropic contributions because government funding is basically stagnated. So many people, in my experience trying to raise money, is, someone had a loved one who was a substance use disorder. They're very touched by that. And they feel they want to make a contribution. So when you could raise money for an agency and bring it to a person's attention, a donor's attention, that what you're doing could help your brother, your sister, whatever, it makes a big dent. When you talk about advocacy particularly, or coordination, or integration, there's not that much of an audience for it, which is a problem. Another one. We should instill in our profession and our work a value to people who are able to collaborate with others. So there should be some rewards for it. So those of you that reach out to other agencies, develop memorandums of agreement, for example, conference protocols, to facilitate the clients getting services they may need other than the ones you're providing, that should be rewarded. I'm not sure it is in most organizations. And of course, we have federal regulatory constraints that often bar you from using federal funds in one program to really provide what a client needs that's related. Surprisingly, one of the upsides of block grants, which have generally been used to control the budget, is the fact that you can transfer money from different grants into one to do other things. I mean, think about this. When I was commissioner, we were spending $100 million a year in emergency assistance. That's hotels, mostly substandard motels. I think of that, $100 million. We could build some housing with that, for God's sakes. And we did, actually. And we provided rental subsidies and other reasonable kinds of responses because we had the flexibility. But block grants aren't that popular, and they also have some deep fall difficulties at all. We had one program that was short-lived, but was a lot of fun, is in welfare, particularly in TANF, you ask yourself, why now? Why does a client come in now for assistance? And when you really look into it, it's not often, it's like another straw on the camel's back. You have a young mom with a few kids struggling, even working, doing the best that she can, and all of a sudden her car breaks down. And she says, that's it, I can't deal with this anymore, I'm going to go apply for welfare. So what used to happen is people would come in, you apply for welfare, they tell you to go home and wait for a check. And we kind of trap people on welfare that way, unfortunately. Because I can tell you, getting along on what welfare pays, to me, is an extraordinary accomplishment. I think we still pay $424 for a family of 3. Could you imagine that with housing costs the way they are today? So, you know, the idea of being able to be flexible, we started a program that fixed people's transmission in that case. We had a contract with it. Someone came in and said, I just can't deal with it, my transmission's broken. We had car repairs. It was crazy, but sometimes the flexibility that comes out of collaboration is the right thing to do. What's going to make this go forward? What are some of the forces that are pressing us forward to maybe have a better system and a better culture they have? One is, I don't believe our costs for many of our social and health programs are sustainable. If you look at even something like Social Security and Medicare and others, you look at the demographic changes in our population, they're wonderful. People live longer, but they still have chronic diseases. And we have fewer people of childbearing age, fewer children being born. So basically the system is going to tilt where you have much more clients than contributors. That's what the problem is, and there's a lot of pension programs and others. So we've got to do this better to both control costs and have better services. Another opportunity, which I'm going to talk about a little bit more, is the federal waivers in Medicaid. If you're not familiar with Medicaid, that's what fuels the children's system of care. That's what fuels community care for the mentally ill and developmentally disabled. Medicaid is actually the jet fuel at $16 billion that funds much of the social service system in our state. And there's been a record now evolving where states have taken waivers to use funds creatively outside the rules with the understanding that they're not going to spend more money and they're going to have better outcomes. I'll talk about one example of that some states are doing and a few ideas. That's a very, very promising area. There's also evolving research. We're beginning to document through our research that there are, in fact, really successes. Analysis of various waiver programs where people have controlled costs but improved and collaborated services on an interprofessional basis. The focus on big data and outcomes is also very popular. And I think we have the ability now to do that. Some people use this creatively even at a community level. The Casey Foundation started funding ideas like this. The idea was to couple community organization and big data. So for example, actually it was done first in New Jersey in Atlantic County. One of your former state senators, who's a friend, came to me and mentioned some of the same data that your freeholder director mentioned earlier, particularly with respect to children. And one of the issues that bothered him was kids of low birth weight. So he said, you know what, let's get together. I'm going to call together a meeting, and as a state senator he could do this, of all the hospital execs, people who run these programs, community leaders, and say, look, our low birth weight rate is up here. Why can't we bring it down here? Let's set a goal. We'll track it through the use of collecting data. We'll direct money to do it, and let's evaluate the results. So it's like, remember the old United Way thermometers where you set a goal and you keep raising it? It was the same effort where people who had some stake, some control could get together and make a difference in a particular data set. Also, the evaluation mechanisms that are put in place by most agencies now are such that people are looking for outcomes and not the same old, same old. Another hopeful change, if you're familiar with organizational and leadership theories, adaptive organizations, those that are able to position themselves to meet the new and emerging needs of their populations, are ones that succeed. And there's a whole theory and base for that that recognizes that you cannot stand still. You'll become obsolete. The world is kind of Darwinian, as a matter of fact, in social service agencies. Those agencies that fail to change are not going to survive. So with thinking like that, I think will result better outcomes. And what I would call learning organizations. I wish I was more of a learning organization person. Here's an example of a learning organization. When we had a tragedy in Dyfus, a child died. The easiest but wrongest thing for me to do was to fire the worker. Everybody wanted me to do that. The governor's offices used to call, not the governor, but some of the staff. Hey, this is terrible, it's unacceptable, fire the person. Show you did something about it. But you know, it belied asking the harder questions. How many cases did this worker have? How good was our training? How strong was the supervision? All those kinds of questions get pushed under the rug when you're not in a learning organization. And I'm proud to see I serve on a number of boards and chair a couple that were starting to evolve in that way. So a different role for organizations. These are all hopeful items we think we could do it. There is a new frontier, and that is the recognition of the power and impact of the social determinants of health. The social, any of you heard that phrase? Are familiar with it? Good, good. It's some of the latest thinking, and I think we're on the cusp. I don't have any inside knowledge on this, but I think we're the cusp of doing something here. As a matter of fact, there have been some big federal waivers given to other states. I understand our state may be working on something to use Medicaid funds to cover them. And my hope is that the driving force of the opioid epidemic to unify services will also be helpful. Let me give you the example of what I'm talking about in social determinants of care. This is a big idea. I'm pushing this at Rutgers and with state government. I was part of a study that the university did. The governor asked us to do it. That his point was the Medicaid program costs are out of control at $18 billion. They're eating up the state budget. So we wanted to know who's using all this money. So we did a very extensive survey through the Center for Health Policy. I didn't lead it, but I was just a part of the advisory group to it. And what they did was identify what they called high utilizers. Who was a group of people that were driving the highest costs of Medicaid, and was there a way we could serve them better at more moderate costs? We kind of had some ideas in this way, but what came out to the degree and extent really shocked us. It turns out that 1% of the Medicaid population uses 25% of the $16 billion. So 1% of the 1.5 million people served in Medicaid use 25% of the resources. It's amazing. And who are those individuals? At first, when I heard this, I thought, oh, these must be very frail elderly in nursing home. It's not. 80% of that 1% had identified behavioral health and related physical issues. They are the big, high utilizers. These are people that are unfortunately sometimes derogatorily referred to as frequent flyers, or more friendly ways, friendly visitors is a better way. I like friendly visitors. They're people who have 15, 20 emergency rooms visits during the course of a month. The bills are astronomical. So the thinking is, you know what? If we covered some of the social determinants of here, particular housing, I'm sure you've heard of the Housing First movement. If we covered housing, if we covered maybe some employment, if we covered some education, that maybe we could make a turnaround here. And I've become convinced that if we, in fact, let Medicaid, the jet fuel of the human services, pay for those social determinants of care, we could actually save money and have reduced morbidity and mortality in this population. The health problems are very severe in many cases. People get blood-borne diseases from using needles and other problems like that. So it's not so simple, but I'm convinced it can be done. And I would love to see the state, and if I were there, still there, I would love to get a waiver from the federal government to try it. We identified cohort of population. Let's give them all those services. In South Jersey here, Dr. Brenner led an organization, I don't know if you're familiar with this, that did everything but pay for the other services. Basically what he did, he was really a true leader in this field, was focused other agencies and brought them together to see if they could reduce emergency room costs by coordinating services. And it worked. I think it worked anyway. There's some research out on it now. The only thing was that he couldn't pay for those other services, so that was a real constraint. But it certainly was the way to go. Okay. Yep, I mentioned this already. Significant was for emergency room care, homelessness, extensive costs. So, expanding Medicaid coverage to cover this for the population would likely reduce costs and improve morbidity and mortality. I really believe that. And combining this with other initiatives, developing a more integrated system of care, could transform a series of disjointed systems into a truly a good system of care. And it's very, very important now, given what we're facing. These are other important practices that I want to bring it down for your use as workers in this field that are important. Things that I would strive to do. Having interagency memorandums of agreement reflecting collaborative protocols that serve clients and patients in a more integrated fashion. So you have an agency, a sister brother agency where there's referrals made, who those referrals go to, what the eligibility requirements are, what each agency is going to do, something about case conferencing, so there's clarity. So you don't send the client over there and they have to start from ground zero, okay? So there'd be also joint case conference protocols, the opportunity for when something's going wrong, one agency doesn't feel the other agency is doing well, the ability to call a case conference without making a big to-do of it. People can get together and under the auspice that we're in it for this client. Joint interorganizational training. We did some of that. It's really effective. It gets you to understand the perspective and the areas of expertise and limits of other organizations that are vital to your clients. Broad-based and collaborative strategic planning. To get together with other agencies at times, how are we going to deal with the opioid crisis in this county? Who should be involved? What should each do? Very powerful. And a good practice would be expand our electronic record systems to also include the information about the social determinants of care, which are vital to case outcomes. These are good things that go on at varying levels at different organizations throughout the state. I think that executives should require this. I think it should be part of our everyday practice. I'm going to wrap up and open up for questions because I hope this has somewhat interested you. Some ideas. Recognizing and rewarding. Using organizational leadership at the executive board level to create a culture of interprofessional and community collaboration. So it's not just something caseworkers should do or mid-level managers. This should come from the top. It should be a culture of times. And when I look back at my own role in a university, I think it's essential for us to create and sustain an academic home for interprofessional research, practice, collaboration, and dissemination of the knowledge that we gain for that to the benefits of clients and agencies. So this is a formidable issue. It will affect you, I'm sure, as your careers progress. And when you get to an executive level or a level you can make some change, you're going to struggle with it. So my thought is if we could talk about it more like we were doing it today, if we could be sensitive to it, I think we could face the future with some hope of success.